the pelvic floor. The pelvic floor is a group of muscles that forms a hammock in the bottom of your pelvis. Those muscles can be weak, loose, tight, or strong. What the function of the muscles is to help support the organs, and they control bowel and bladder function. They have pressure through the abdomen, and they support pelvic viscera, and they control the contraction of the vagina and the penis. So everybody has its pelvic floor, men, women, everybody has one. Right now we are only treating women. We haven't been to the continuing ed on men. We're planning on doing that in October sometime. So we are only treating women right now. But there's a group of muscles on the base of the pelvic floor. That's the outermost muscles, and then there's a second layer, and then there's the inner layer, which is the layer that we are most treating. Is the layer that supports all the pelvic organs. All right. So the pelvic floor acts like, so if you have the organs that are sitting. I know. All right, I can't talk without my hands. So you have the organs that are sitting, and then you have the ligaments that attach to each side of the pelvis. And then the pelvic floor is like the water underneath the organs. If you turn to the picture, you can see the two ends of the pelvis. Page 3, yeah. 2 ends of the pelvis. And so the organs are the triangle, and so the ligaments support the organs. And then the pelvic floor is like the water. So when the pelvic floor gets weak, everything drops. So all the organs drop, everything falls. So that's why we're trying to strengthen those and lift those back up. So the pelvic floor and the diaphragm work together. So you have the diaphragm, which is your breathing muscle, and then you have the pelvic floor. And so they have to act in concert to create abdominal pressure. So, what are some diagnoses that would benefit from pelvic floor rehabilitation? Urinary incontinence, bowel leakage, pelvic pain, constipation, pain during sex, postpartum problems, prenatal issues, prolapsed uterus, bladder, bowel, dysmenorrhea, and vulvar pain, pudendal neuralgia, anything like that. So we got interested in this mostly because of the rate of incontinence that we know of. Incontinence is not normal, no matter how old you are. Women between the age of 18 and 59, 26% have involuntary leakage, including elite athletes. That's actually becoming more prevalent because they're strengthening too much of their rectus abdominis muscles and not enough of their pelvic floor, so they're actually becoming more of a problem for urinary incontinence in the younger generations. And then, so women over 40, 20% also have overactive bladder, which means 44 to 57% of middle-aged women have some kind of urinary incontinence. And then 75% of women over 60 have some kind of incontinence. And urinary incontinence is twice as common in men as in women, and it's one of the leading causes of nursing home admission. So those were some of the reasons we decided that is a huge group of people we weren't interacting with, and we weren't trying to help. And so we decided to do this training to see if we could help anybody in that area. So there are three main types of incontinence: stress incontinence, urge incontinence, and overflow incontinence. And then there's a mixture of some of them. All right, so the bladder acts as a storage reservoir. So all it does is it's a low pressure reservoir, so urine just runs into it. So the first desire to void occurs at 150 to 200 milliliters of urine. And the bladder remains relaxed until 200 to 600 milliliters. And then the sphincter and pelvic floor contract to hold all that up. So hold the urine in and hold the bladder up.
So it's all muscle. Right, so your bladder is a muscle. So your bladder is a muscle, and so it's trainable. So, you know, I have kids, bless them, but they are potty training. I have a 3-year-old. And so we tell them, all right, you can't drink an hour before they go to bed, so they don't go to the bathroom at night. And so what we're doing is a lot of education, a lot of training to help with those urgencies, because what happens is we start training them. We start saying, oh, well, I'm about to do this long community event. I have to go to the bathroom before I start because I don't want to get up during the middle of it. And so we do a lot of education to kind of help stop that what we've trained ourselves to do and what we've trained the bladder to do, because it is a muscle, so it's like anything else. Once you kind of exercise it in the appropriate way, it'll get better. There you go.
All right, so there are some bladder health tips. So if you want, so the bladder is very trainable, like she said. So it's a muscle, so you can train it. So you want to work on some of these things that will help with just bladder health. So you want to go to the bathroom every 3 to 4 hours. So that equals about 5 to 7 times in 24 hours. No just in case urinations, so don't go to the bathroom just because I'm going to get in the car, or just because if you do that often enough, then you have to go to the bathroom just before you get in the car, or just before. And try to go for a steady stream of about 8 seconds. And sit on the toilet. Don't hover. No matter where you are, don't hover. We're not in the society that actually, some societies don't actually sit, but so if you're used to going to the bathroom sitting, sit. And no straining, so try not to make yourself go. And no nighttime just in case either. Avoid constipation. Drink enough water. Half your body weight in ounces. So if you weigh 120 pounds, that's 60 ounces of water a day. So avoid bladder irritants. Avoid before or after sex. Try to avoid pads. That just irritates the vulvar area and makes you more susceptible to other problems. And perform pelvic floor exercises, and orgasms help with bladder health. Okay, and so some bladder irritants. This is just a list of some of them. There's a lot. Alcohol, apples, ascorbic acid, cantaloupes, carbonated beverages, citrus fruits, coffee, peppers, pineapples, plums, strawberries, tea. So when we are doing the treatment, we actually have you do a bladder diary, and so we do it for a week, and we see what you're eating, see what might be irritating it, and see what could be causing some of the irritation or some of the problems you're having. So we can offer different variances of your eating habits and drinking habits.
What page are you on?
Oh, sorry, 8. Sorry. This was a presentation originally that was much longer, so I'm trying to
Skim.
All right, and so then we can also treat prolapses. There are uterine, bladder, and bowel prolapses. We can only treat from grade 1 to 3. Past that, it gets to a surgical point, and we are not surgeons. So we don't do that. But it actually can help strengthen the pelvic floor, can help lift. And we have dilators, we have all sorts of things that we can provide to help this. And it's an option before you go to the surgery. If you want to try it before surgery, it's not going to hurt anything. So. And then there's also diastasis recti. It's usually after pregnancy, but not always. It's when your rectus abdominal muscles separate. And so therapy can help bring those back together and form better strengthening into those muscles. So how can we help? So we can identify tight muscles, weak muscles, pain, function, and how your back and your pelvis and everything function together. And we can identify postural problems and discuss issues that the patient wants to work on, and develop a treatment plan for deficits that involve the pelvic floor. All right, So how do you get help? So discuss with your physician, and you can get an order for therapy. It can be any physician, it can be your general practitioner, it can be anybody. And you have to be open with your open about your issues. So this is not a topic we like to talk about in general, but it's something we need to be more open about. And so you have to be open to us and willing to tell us what your problems are. And be willing to change and adapt, and that's a big one. So you have to work at this. This is not going to get better overnight. It's something you have to work on. So during the initial evaluation, what we do, we do an internal exam optimally. The internal exam defines what muscles are weak and what muscles are tight, where you're having the most issues. It's not absolutely necessary, but it helps a lot, because the only way to get to the third layer of muscle is going internally, because it's deeper than you can palpate on the outside. And then we'll provide education, and then we'll do customized exercises depending on what you specifically need. So there are issues with too tight a pelvic floor, and that causes a lot of pain usually. There's issues with too loose, and then you have to do strengthening, and there's lots of different issues with different muscle groups. And so depending on the need, we can do manual therapy, which is working on the muscles around the pelvis and into the low back and making them looser and more mobile. We have biofeedback. If anybody's interested in that, we actually brought that with us. And we can provide extra electrical stimulation if the muscles just won't work and they're really weak. All right, so we're going to do a few exercises just to kind of give you an idea of something we'd be doing in therapy. So for relaxation purposes, a good exercise is diaphragmatic breathing. And this is for everybody, anywhere. It's good if you're fixing to fall asleep. It's good for anything like that. So what you do is you put a hand on your abdomen, okay, and you're trying to breathe into your hand. Okay, so you're going to try to expand your stomach as far as you can into your hand. And do it real nice and slow. And then you breathe out. And out, and try to go all the way in. And then you breathe back into your hand. And out. So the easiest way to do this, if you can't really feel it moving, is actually in laying down. So if you can't feel it moving real well, try it at home. And it actually turns on the sympathetic nervous system and actually makes you fall asleep easier. So it's a good way if you have a problem falling asleep. It's a good way to just do some deep breathing, and it'll help with that sometimes. Anyway, and then so now an exercise for the pelvic floor. So you have to pretend like you're trying to suck a milkshake up your vagina. So you're going to pull everything up as high as you can and hold it and then relax. Okay? And so this is just the starting exercises, and then you eventually try to hold it and do something else. And then you try to hold it and do something harder. Lift. You try to hold it and do something else. So you just go on that. And with the internal exam, we'd be able to see if you're going all the way to the top and actually contracting the correct muscles. Anyway, so a treatment of therapy would be you'd be coming for about 8 weeks usually, and you usually come about once a week. We do a bladder diary with nearly everybody just to see if there's any irritants that we could recommend you avoid, anything like that. And the exercise prescription is you're trying to do 30 to 80 repetitions a day with a 10-second contraction, a 10-second hold. So this is throughout the day, so you have to do it throughout the day. So a good cue is if you're going to do something that you know makes you leak, makes you do something, you stop, so you freeze, you squeeze, and then you do the exercise. So this is just a new product, new line of therapy we're offering. I've been a therapist for 15 years. Patty's been a therapist for 7 years. So this is just something new we're doing. And we're having some success with it. So if you want to join us, we're there. Thank you.
Hi, I'm Dr. Zapata. Can everybody hear me? Am I close enough? All right, so that was a very good presentation. Oh, that's okay. And my approach, I don't know many of you, but I do recognize many of you out there. When you initially come to the office, what I like to do is, as any doctor does, we do a complete H&P when we're talking about pelvic floor abnormalities. If you had a baby, you have a pelvic floor abnormality. Let's just put that out there. And most of us have children. And the more you have, the more your abnormality is. However, not all abnormalities are necessarily quote unquote abnormal, okay? Because there is different variations of prolapses, okay? She said there was stage 1, that they treat stage 1 to 3, and then there is stage 4. Every woman who's had a child has a stage 1. It's a natural process of pushing. Even if you had C-sections, you will have a stage 1 just because of the natural pressure of growing a human being in your body. What's the big thing about this is how it affects you. If you have no symptoms, 9 out of 10 times, there's no indication for intervention, because when you try to fix something that's not broken, then you make any problems sometimes. So unless you have a symptom specific to a prolapse, that's when we intervene, whether with rehab therapy or surgical intervention. Most women have experienced some type of incontinence, and of course I'm going to let the expert, Dr. Liskell, talk a little bit more about that. And there are varying degrees of how we intervene. What I'm going to focus on is the pelvic floor abnormality. The most common one that we women feel is like, I went to the bathroom and I felt a bulge when I wiped. That's how most women that come to my office complaining of prolapse present. I felt something wasn't right. Is it abnormal? What is it? I took a mirror, that's the best one. I took a mirror and there was something there. And it's true, that's what you'll see. But once again, what I'd like to stress is it's only abnormal if you have symptoms that are associated. Many other things how it presents is you have intercourse and your husband felt something, or I'm sorry, I lost my train of thought, I apologize. That's why you should take notes. Write down notes. Or there's, like, you're doing something with your children and then you felt something. I mean, those are, like I said, common presentations. So when you come in, we do a full physical exam, okay? The problem is with exam is when many of us come to our gynecologist, we put you on your back. You're like, okay, that's not when the bulge is present. The bulge is present when you're cheering your kids on, or when you're, standing up, not when you're laying down. When you're laying down, everything goes back, So same thing down there. So what we have to do is also examine you in a standing position. It's really key. We do the initial exam laying down. We do what's called a bivalve exam. What that's basically is you take the speculum, you split it in half, and you see where that defect is at. Is it anterior, is it posterior? Because that guides our treatment of you. And then finally, we do a standing exam, okay? Because that's when most women feel the abnormality. So we ask you to stand. During these testing, we ask you to push down, bear down, Valsalva. And then that kind of tells us the severity of your disease. Like I said, everyone, if you've had a pregnancy, you're a stage 1. And that's not, like I said, that is not considered abnormal. And what we mean by stages, it's all based on the hymal ring, okay? Everything is based on how far we are from the opening of the vagina. Now, the second thing is, when I'm speaking around, we're talking about the woman with the uterus and it's never had any surgery. Well, then we have other abnormalities, and that has to do with the patient that's had the hysterectomy. The hysterectomy may not have been for prolapse. It may have been for abnormal uterine bleeding. It may have been for fibroids. I mean, there's lots of reasons why hysterectomies are performed. There's things that when you do have a hysterectomy, you also want to speak to your doctor about because that's when you say, okay, I also feel pressure sometimes. I feel this, I feel that. And then there's also corrective pressures, corrective surgical interventions when we do hysterectomies to prevent prolapse. Because it's not just, oh, let me take your uterus out, see you later, because we'll see you in 10 years for your prolapse if we don't do something. So those are very key steps when you go and speak to your doctor. Not everybody needs a support when you did a hysterectomy. That's not necessarily indicated. It's when you have some defects that also require that additional repair so that we do not see the prolapse. Because the literature shows that if you do a hysterectomy for someone who's already showing a prolapse, you're going to have a prolapse. It's inevitable. It's just, we already know that the tissue quality isn't to what it's supposed to be. There's also non-surgical approaches, okay? I don't think Dr. Potter's up there trying to cut some uteruses out and fix some bulges. There's non-surgical approaches. Dr. Lisko and I, we constantly refer to each other. There's the pessary, okay? It's not ideal for everyone, but it's definitely an effective form of therapy. And pessary is basically, it is a type of device that's inserted vaginally to keep everything that's prolapsing up. There's different types, and that's also based on the type of prolapse you have, whether you have a uterus. We have to think about age, because these do have to be taken out. We also think about sexual activity. I mean, when we're younger, we're more sexually active. There's also, some limitations because we don't, hold on, gotta go take my pessary out, honey. You know what I mean? And even though we're very open with our husbands, many of us feel a little bit uncomfortable talking about these things, whether it's to our husband, to our best friend. I mean, I have to pull it out of y'all, and not to be blunt, I see many of y'all naked, and y'all still don't want to tell me things. I'm like, you gotta tell me these things. I can't help you if you don't let me help you. And that's the main point. You gotta remember when you go to your doctor. It's if you only tell them half the story, then you're doing yourself a disservice. And sometimes you think, oh, I'm going on and on and on. Not necessarily. Sometimes we're like wanting you to tell us things so that we can help you. And if you're going on and on and on, sometimes we're like, Miss Wright, we'll talk about this next visit. You had 5 problems today. No, I'm just kidding. But nonetheless, and the repairs they can be site-specific, they're generalized. I don't know how in-depth they want me to go in today, but I'll just do a very, kind of, I'm telling you, my English is just leaving me today. I'll do a brief talk about the surgeries. One is the cystocele, okay? It's exactly what it means. It's the bladder. You fix the bladder defect. It's the anterior aspect of the vagina. That's the bulge that you feel when you're urinating or when you're pushing down. And the other one's the posterior. Many women, their biggest symptom they come in is that they have to press the posterior aspect of the vagina to move their bowels. Okay, that's a posterior defect. And then sometimes you have the uterus prolapsing, or if there's not a uterus there, the pelvic, the anterior aspect, the apex of the vagina that protrudes. And then she didn't mention, she said they didn't do 4, and I can understand why. 4 is when your uterus or your vagina is hanging out and it looks like male scrotum. Don't let it get that bad, women, because it happens, and we just got to be proactive with our care. Mesh is out of the market. Okay, FDA several years ago pulled it off the market. Said the risk was not worth the reward. So mesh is off the market. We have to use native tissue. We have to use permanent suture. There's other things we have to use. This has also affected our care, and it's affected our success and failure rate. The biggest culprit to prolapse is constipation, chronic cough. Those are things that, when you go into rehab, you talk about, okay, do you have chronic constipation? What do we need to do to fix that? Because if you're 30, have chronic constipation, you will be in my office or someone else when you're 50 with that rectocele. It's inevitable. It's just, it takes the path of least resistance, and unfortunately the vagina is the path of least resistance to the bladder and to the rectum when it comes to pressure. So, like I said, we do site-specific. Sometimes, sometimes you get everything. You get the hysterectomy with the anterior, the posterior, the support. And there's different approaches. There's laparoscopic, there's vaginal. There's very few physicians now do a complete open, but sometimes that's the candidate you are, and it's not very common. Most people usually intervene vaginally or laparoscopic. It all depends on the severity of your disease. Our job as the doctor is to guide you, to give you information, and kind of help you direct the care that is best for you. Like I said, and it's not always surgical. Sometimes it is, therapy, which I preach in my office. The Kegels. There's other products that are online, which it's sometimes for patients and myself, because it's uncomfortable sometimes to talk about these things. But they have like the Boschy balls, they have the dilators, they have various items that you insert at night and try to maintain your vagina to strengthen your vagina. So those are things that we have to get comfortable discussing, because the population's getting older and we are all healthier, and then we also have to be proactive with our care. Like I said, another big culprit in the office is the stress incontinence, and so with that, I'm going to pass this to Dr. Lisco. I'm sure they'll have some.
Hello, ladies. I gotta tell you, I don't think I've ever been in a room this outnumbered. Okay, so. I know. So, as everybody knows, I'm a urologist, and this is just my take on everything everybody's talked about, coming at it from just a little different. And I'm going to stick to what the young ladies talked about, really three things: stress incontinence, urge incontinence, overflow incontinence. So I want to be clear that everybody knows the difference, first of all. Stress incontinence. Does everybody really know what that is? Okay. Well, I can tell you what it isn't. It isn't my husband and my kids are driving me nuts, so I'm leaking urine. It's not. Okay? Stress incontinence is, by definition, the leakage of urine whenever you cough, sneeze, laugh, any type of Valsalva maneuver that pushes from your diaphragm on your bladder that causes leakage. And specifically, it's really an anatomical problem. Of all the incontinence, is really the one that is due to a change in the anatomy. Okay? And we're going to I'll get into that a little bit more, but specifically, stress incontinence is also the only type of incontinence that really is a surgical problem, or can be a surgical problem. The other types of incontinence, both urgency and overflow, are generally treated medically, and I am a big fan of pelvic floor therapy. I really am. I want to talk real quick about urgency. Urge incontinence. Urge incontinence is basically when people come to see me, doc, I'm going every 15 minutes. Stop the bus. I can't hold it. I can't hold it. Now, the first thing I do as a urologist, it's you label something as urgency and urge incontinence, but what you got to make sure of, there are other reasons for urge incontinence other than just simply an overactive bladder. And this is where I feel strongly about this, in particular if there's anybody who has blood in their urine. There are other things wrong that can cause urgency. Just to give you an example, stones, urinary tract infections, bladder tumors, anything that's in the bladder that doesn't belong there can certainly cause urgency. But what you don't want to do is just label somebody as having urgency when they have actually something else going on. That's my job. So when you come to my office and you have urgency, and all incontinence, you're going to get really two or three things. One, you're going to get a thorough exam, and to take it a step further, if there's any evidence of any bleeding or any blood in your urine, I'm going to want to look in your bladder with cystoscopy. Maybe some of you have done it in my office. It's virtually painless. And I also do something called urodynamics. Urodynamics is, the way I describe it is, it's like an EKG of your bladder. We look at how your bladder fills. We look at how it empties. We look at how it fills and empties in coordination with your sphincter, which is the muscle that is always contracted until you void when it relaxes. So it's a very simple test. It does take about 45 minutes, and our nurses do that. And I use all these modalities really to make sure we're not missing anything other than just an overactive bladder. regarding overflow incontinence is basically you're running around with a full bladder, and the only time you void is it just overflows. The bladder's completely full. You see it a lot in men who have had, prostate surgery or need prostate surgery, and they come in and they'll have literally a liter in their bladder, and they don't even know it. So they're just, doc, it's just running out. That's overflow. Not too common in women as it is in men, but that's the definition. Now, when we talk about treatment options for stress incontinence, as I told you, is really one of the only surgical options. And it's a little different than what Dr. Zapata does. I'm talking about working primarily not on the bladder, but more on the bladder neck, which is the urethra. And using that type of surgery, there are still mesh on the market for that particular type of surgery, which I use. And I'm very vocal about it, and I disclose that. It's not the mesh that was taken off the market. The mesh I use has been on the market, it's been safe, and I've had virtually no problem. But I do disclose to you that I'm going to use it. Actually, by law, you have to sign a special permit for it. But what it does, it's done properly. It's an instantaneous correction of stress incontinence. You will go from leaking when you cough, sneeze, laugh to not. It's that fast. It's not a gradual thing. You'll know it the next morning when your catheter is removed, or that day. So it's dramatic. And for a dignity, it's unbelievable. Obviously, the last thing we want to do as adults and humans is we'll run around with diapers, because every time we laugh or have a good time, we're basically peeing our pants. You can stop it, okay? The key to stopping it is to make sure, A, you make the right diagnosis, and 2, you do the right procedure. And that's sort of where we come in. The difference between what I do and what Dr. Zapata does, with a prolapse, where the bladder is dropped, and almost nobody with a prolapsed bladder has stress incontinence. But and she'll probably agree with me in most of the cases, if you correct the rectocele, or excuse me, the cystocele, that's how you create stress incontinence. So basically, during a cystocele repair, we'll usually do both. Correct the cystocele and then fix the bladder neck. And basically, if you look at some of the handouts, I have them here somewhere, but basically all we do is create a hammock around the urethra. It's done, I do them literally in about half an hour, outpatient, through basically 2 little incisions anteriorly and a small incision in the vagina. Half an hour. That's after you've been diagnosed and properly diagnosed, okay? Now, that's not to say that pelvic floor therapy doesn't work for stress incontinence. It does, because we have a lot of patients who simply, doc, I don't want any surgery. Fine. I'm going to go out on a limb and say almost no real medications work for pure stress incontinence, because as I told you, it's really an anatomical problem. The urethra is not where it was. It's changed. Urgency is exactly the opposite. Urgency, provided that you've ruled out bladder tumors, you've ruled out infection, you've ruled out everything else, is almost exclusively treated medically, or I'm a huge fan of their therapy for urgency. Now, I personally use medications, anticholinergics, which will relax the bladder. That's after you've had your workup. But the only time I would do any surgery, you like this, with Botox. Yes, Botox in the bladder. Yep, it works. So we're doing it. It's kind of neat. It's about a 10-minute procedure. And I use it for really refractory overactive bladder, meaning we've tried everything else and nothing else has worked. Other than that, if you're not interested in the medications, or the medications aren't working and you want to try an alternative therapy, the young ladies are here. I guarantee you I'm going to use them. There is no doubt in my mind I'll have patients to refer to them. I'm done. Any questions?
This video has been brought to you by GEUS 34. GEUS is your community-owned provider for electric, internet, cable TV, and true local programming.